cells. But look at P53. Would I call this? Absolutely not. Okay? We can mention it in the comment, but not more than that. And this is very elegant study. They looked at P53 mutation in the resting endometrium, endometrial glandular dysplasia, serous AIC, and invasive serous carcinoma, and it was identical mutations. And they were like, okay, this is a precursor lesion. But again, it might be confusing. I would mention it. To start with, it's a rare disease, so it's not that often you see it. And I always ask for another DLC, you know. This is the best to follow up the patient. So, and look at the endocervical glandular dysplasia, P53, the difference, and Ki67 is not as intense. So close follow-up is the recommendation. Some pathology staging issue, I thought, do you remember the old staging system? It was 1A, 1B, 1C. 1A, no myometrial invasion. 1B, less than 50%, 1C, more than 50%. The survival rate was so close between 1A, 1B. This is why in the new staging system, they lump it together for all endometrial carcinoma. We did a study for serous carcinoma was not really fair for this lump, you know, because no myometrial invasion, some of them, they didn't behave as well. This is why really pay attention to the one with no myometrial invasion. That was the message for us. The cervical involvement, I won't mention too much about it, 2A versus 2B. Now it has to be 2B. So the new staging system, 1A less than half of the myometrium, the invasion, 1B more to the outer half, 2 cervical stromal invasion, okay? So this is the new staging system. I'm sure all of you use it because it's not new anymore. Tumor size, we did the study, it correlates with survival. And in serous carcinoma, 1 centimeter was the cutoff. And it's not part of the staging, but it's required to put it in your report, the tumor size. It is a risk factor. The same as the vascular invasion. And you have to say the extent of vascular invasion. Is it very extensive or only rare foci? Again, it's another risk factor, and we published on it. I don't have the slide. Moving to another topic, it's related to the same, the mixed serous carcinoma, because sometimes it's not all serous or it's not all endometrioid. How about having them together? Let's see. 1/3 of the serous carcinoma coexist with other subtype, endometrioid, clear cell, or neuroendocrine carcinoma, which is eventually rare in the uterus. Trophoblastic differentiation has been also reported, but probably in case report. So the most common one is the endometrioid and the clear cell. When they start, it was, if serous component 25 or greater, it will behave the same as pure serous carcinoma. Well, the cutoff now by WHO, 10% of serous carcinoma, you call it mixed. And this tumor will behave really like serous carcinoma, okay? And even, this is by WHO, 10%, any component of serous carcinoma, I mentioned it. And what would you say? Would P53 highlighted? It depends on the other component. If it is high-grade endometrioid, it will be in both positive. So you don't want to, I mean, it will be fine calling it mixed with serous predominant, even if the serous is small. But any component, I put serous carcinoma, and I tell my fellows, serous is really serious, all right? So at least they keep it in their mind. Look at this. The top, serous carcinoma, the bottom, endometrioid. Again, this is from the top field. It's very blue, it's very rugged, kind of like dirty in the space between the glands. And look at the sheet of malignant, but way less cytologically atypical case. This is courtesy to Dr. Crum. This is not my case. The serous carcinoma highlighted by P53, the endometrioid, and it has some mucinous differentiation, was negative. So the other part could be very well differentiated, could be mucinous, secretory type, squamous differentiation, you can have any other type. But the key and the message is to really write that component there. I was very interested in this mix, and we did a study a long time ago. This is part of the staining we did. P53, look at the difference. Again, we call it a Christmas tree, that it is diffusely positive. This is the endometrioid component, was few cells here and there. The HER2 was positive in both, kind of. P10, it's positive in the serous, negative in the endometrioid. Okay, because by definition, endometrial carcinoma, you have mutations in P10. It's truncated protein. It will be negative in the immunohistochemistry.
But about the estrogen and progesterone receptors, any difference between the types?
In estrogen, progesterone, it will be negative here for sure. Okay? For sure, 100% I can't be, like few cells might be. And it depends about the differentiation and the grade of the other component. If it is well differentiated, it will be positive. If it is high grade endometrioid, it will be negative. Okay? Okay, so what's the differential diagnosis? We have two parts of the differential diagnosis. Malignant, or malignant benign. So let's start with the malignant, and why do I have to differentiate between both of them? Of course, there is a big difference between biloglandular or FIGO grade 1, behavioral-wise, with serous carcinoma. And there is another lesion, it is FIGO grade 1. I don't give this name, but it is in the literature. I call it FIGO grade 1. I'll show you the example. FIGO grade 3, it has a story. I'll go over it. Clear cell. It has similar hotmail, but different other criteria. So look at this biloglandular. Look at the lining. It's papillary. It's finger projection. But the lining, mild to moderate cytologic atypia, not more. Look at the other one. I have the projection, I have the villus, but the nuclear atypia is way more. The necrosis and the debris and that schmutz in the middle is different. It's way too blue, right? So we have really to appreciate both of them. Well, here is well-differentiated serous carcinoma. The other, okay, I won't say any words. Who would tell me this is serous carcinoma? There is some papillary projection. There is a little bit debris in. Raise your hand if you say serous. Well, I'm glad no one said serous. It's not serous. It's FIGO grade 1. And I had to do P53 for one of our oncologists because he said, no, this is papillary and it is there. We presented in the tumor board. I'm like, you have to trust me. And look at the other one. This is the serous glandular type. Okay? It has similar look, but again, the lining, the malignant cells are different. Clear cell carcinoma, the only two features that they overlap, sometimes the hotmail, but the hyalinized core is different. And in clear cell, it is in type 2 carcinoma, but it is honestly a mystery. Still, there are so many things to learn about clear cell carcinoma we don't know. P53 is negative in clear cell carcinoma. Not 100%, but at least in 80% of cases. So a lot to know about clear cell carcinoma. It's aggressive disease. Serous carcinoma, it share again the hotmail, but it is different. How about endometrioid FIGO grade 3? It has criteria that we have to see more than 50% solid sheets, right? This is by FIGO definition. You have to have more than 50% of solid sheet. It can be in a different papillary, very few, but solid is the most. And nest frequently, The nuclear feature is high. It is really significant cytologic atypia. The serous, it's more papillary, and the lining is different. This is an example of high-grade FIGO grade 3 endometrioid carcinoma. There are a lot of debatable about high-grade FIGO grade 3 endometrioid carcinoma, and this study, I think it was like 25 cases of high-grade endometrioid carcinoma divided to 3 GYN expert pathologists. They did not agree among themselves. So there is a lot of poor intra-observer variability in endometrioid adenocarcinoma, the FIGO grade 3. And we did this study looking in the 2 institutions. Ours, that we read everything, we are not subspecialized, versus the subspecialized Sloan Kettering, and it was difference, the inter-observer variability between both of them. So the debatable is FIGO grade 3 in type 2 or in type 1. And the other debatable, would FIGO grade 3 do worse than serous or better? All 3 of them will do the same. And still it is debatable in the literature, and this is from the largest series in the state. It's from SEER database. It's a huge cancer registry. That FIGO grade 1, it's the most frequent, the incidence of it. 10% serous, 3% clear, and FIGO grade 3. The incidence of death from serous carcinoma is the highest, second by the endometrioid FIGO grade 3, clear cell, and FIGO grade 1. Did you put the time together with the... Yeah, can we? I know, but it's okay. I don't have to shut up. I can keep 5 minutes. So the second differential diagnosis, which is really crucial to know the difference between benign or malignant, the metaplasia, endometrial metaplasia, and the one associated as simple as with shedding. Look at some of these examples. This we call it hobnail metaplasia. You know, this is the name. This is hobnail. Look at this. There's not a lot of hobnailing here. Look at this one, or this one. Sometimes with a little bit cytologic atypia. But guess what? There is not even a single mitosis here. And a lot of cytoplasm. The NC ratio is low. Another example can be really scary. And we see a lot of this in the consultation service because you do not want to miss serous carcinoma, but at the same time, you don't want to overcall serous carcinoma. So let's go through some of these cases. Shedding with features sometimes worrisome for serous neoplasm. Let's look at this case. Look at the low power. A lot of shedding in the background. And the clusters, you have it all. But look at these here. High power. Honestly, this scared me. You know? But P53 was negative. Look at the high power. So it gets really confusing and really difficult sometimes. Yeah, this one. Again, the key is no mitosis, low NC ratio. Whenever you are in doubt, P53 will help you. And I always do P53 and Ki67 because there is no proliferative rate here at all. Okay? But again, it's not every shedding is benign. Look at this. So who would tell me this is positive or this is metaplasia? Is it serous carcinoma? Is it shedding? Metaplasia? Raise your hands, guys. Come on. We put the light so I can see you. Stay with me. Serous carcinoma? Well, I mean, you won't lose anything. I won't know who you are, so either raise or not. You have to participate with me. Okay, let's go back. No, I'm not putting high power. From this power. Okay, what do you think? The panelists? No, you just, okay, fine, I'll put high power. was positive. Okay? It's too blue, you know? And I know, I put it just for the interaction. Not every single shedding is benign. Whenever you are in doubt, do the P53. Okay? So we have eosinophilic pink metaplasia. Look at the surface. This is tubular metaplasia. Beautiful. You got the cilia, it's benign. And look at the top. It's ugly, but it's metaplasia. The hotmail is sometimes, especially if you have previous DNC, we call it re-epithelialization, so it gets really worrisome. How about this one? What do you think? Metaplasia, raise your hand. Carcinoma? So 50-50. There is not a single mitosis. It's only the hotmailing. There is one mitosis. Alright, I'll go back. No, this was metaplasia. We call it mitoid. This is not mitosis. And believe me, sometimes I doubt myself. So, okay, even I'm here, and it is mine. It's very difficult, so do the stains, okay? Let's look at this case. Look at the surface. This is different case, okay? This, I did P53. Believe me, I don't look at like I'm a hero with this case. It's absolutely not. It's very scary, and it's a lot of responsibility, and it means a lot for the patient. Some physicians even, they give chemotherapy for this disease. Look at this. This is P16, cytoplasmic and nuclear. And look at P53. It is diffusely positive. Okay? So it gets really tricky. How about this case? This is in DNC. Okay? They're very blue. And they're very ugly. But I agree with you. Even this atrophy, go high power. Any patient more than 60 years old, I take it very serious to call it, the way I sign my cases, strips of inactive endometrial epithelium. Okay? And if I'm in doubt, I go, of course, high power. And if I'm in doubt, I do P53 and Ki67. This is the high power. So, tell me, serous carcinoma? Raise your hands. All of you. That's wonderful. It is. Look at this. It gets so tricky with these cases. Okay, this is my last case to share. I started late, so I'm okay. Okay. How about this one? I'll go one high power. Just different view, sorry. So, serous carcinoma, raise your hands. All right, I got only very few, which is good. Okay. It is papillary. It's very complex. Look at the cells. The cells are not bad at all. And it's clean. The key, I make a lot of fuss about how clean it is there proliferative rate there? It's my HNE. But it is very worrisome case to stain for Ki67. Okay? It's very low proliferative rate. And it is polyp with complex papillary hyperplasia. I don't put the hyperplasia, it's another talk, in two boxes, either complex or simple. Well, sometimes you can get in papillary hyperplasia, sometimes you cannot tell. So you can just describe what you see. And how about this one? Serous carcinoma? Yes. All right. Look at the floating small papillae, the hubnailing. Oops. Ki67, P53 positive, the same for Ki67. How about this one? It's the same case, okay? So always pay attention, and this is my last slide. And it was after the chorotic intraepithelial carcinoma, serous intraepithelial carcinoma. Thank you so much, and I'm sorry about